Good afternoon, everybody. Thank you to Sages for the opportunity to present. My name is James Taylor. I'm a general surgery resident at Johns Hopkins, and I'm here to talk about our experience of implementing a bariatric protocol for ERAS. None of the authors have anything to disclose? So the history of ERAS really dates back to the late 1990s when a series of post-operative fast-track protocols and implementations were introduced to try to safely help patients to leave the hospital in a quicker manner, in a safe manner. Since then, it's really evolved into a multidisciplinary preoperative, intraoperative, and postoperative series of protocols which have been successfully implemented throughout a variety of surgical specialties, most notably colorectal, urology, and thoracic, to name just a few. The benefits of ERAS are well documented. Definitely a significantly reduced length of stay, reduced costs without compromising quality, increased capacity at surgical centers, and also safe. It's been shown not to increase readmissions or complications. However, the uptake in bariatric surgery has been a little bit slower than other specialties, and the reasons for that are probably multifaceted, including complex patients with multiple comorbidities, complex procedures, and a lack of real robust clinical evidence. The evidence that is currently out there has been summarized well in a couple of large meta-analyses and systematic reviews. They've definitely shown that there is a statistically significant reduced length of stay with introduction of ERAS protocols. They've also shown that the ERAS protocols that are out there are safe, so no increase statistically significant, that is, in readmissions or complications. And very few studies have looked at the impact of cost, but you can see there is a trend towards significance with ERAS protocols. However, one of the biggest criticisms that's come up in a lot of literature has been a lack of homogeneity between the ERAS protocols. Many have been translated from other surgical protocols, like the colorectal ones. Some have been independently created by surgeons at institutions, and others have been taken from international bodies such as the ERAS Society. So the MBSA set out to introduce their own standardized ERAS protocol termed Energy, which I'm sure many of you are familiar with, and in 2016 it was implemented at Johns Hopkins. It has several overarching themes, mainly to avoid IV opioids, early ambulation, early PO intake, minimizing IV fluids intraoperatively, and as you can see here, it hits a patient during every part of their stay, preoperative, intraoperative, and postoperatively as well. So as I mentioned, it was introduced in 2016, and we sought to compare our pre- and post-ERAS periods, so 2015 to 2017. We looked primarily at length of stay and total cost, and secondarily looking at readmissions and complications. And we took our data from the Premier Health database. This table just shows our demographics. You can see here there were 277 cases in the pre-ERAS period compared to 348 in the post-ERAS. That's a 25% increase, first of all. There was no significant difference in terms of the age, race, or procedure types, but we did have a slightly higher proportion of female patients in the post-ERAS period. Our length of stay was dramatically reduced from 2.77 days to 1.77 days on average. And this chart quite clearly shows, and is quite dramatic, that in our pre-ERAS period, we had less than 5% of patients being discharged on post-op day 1, compared to over 50% in the post-ERAS period. We then went on to perform multivariable regression analysis to further identify the factors associated with length of stay. As you can see, I've highlighted some of the key ones here. ERAS introduction significantly reduced the length of stay, and when compared to sleeve gastrectomy as a reference, open gastric bypass and laparoscopic gastric bypass were all associated with an increased length of stay. Our total cost, our median cost, per patient was reduced from $11,700 to $9,500 per patient. That translated to a net savings of over $800,000 for a calendar year for our institution. We performed, again, regression analyses, and I highlighted several key factors associated with costs. As you can see, the ERAS introduction reduced the cost per patient. Interestingly, for every 1 year that a patient gets older, the cost of the procedure goes up by $26. And when compared to the sleeve gastrectomy, all other procedures were more expensive. Looking at our readmissions and complications, apologies for a complex or busy table here, but I'll point out the key things. The introduction of ERAS statistically significantly reduced the risk of readmission, but it did not affect the risk of a complication. When looking at the procedure types, you can see that sleeve gastrectomy as the reference, open procedures were associated with a higher risk of readmission, and when sleeve was the reference, there was a higher risk of complication for all other procedures. So at Johns Hopkins, the standardized ERAS protocol was successfully implemented, and it translated to a reduced length of stay, reduced total cost, reduced readmission rate with no impact on complications. And we had a dramatic increase in the number of patients discharged on postoperative day 1. Every study has limitations, and ours is no different. It's an observational study, so it's open to the bias associated with that. We took our data from the Premier Health database, and we didn't have access to as much clinical data as we would have liked. The reduced length of stay may have been influenced by surgeons and by the surgeon experience when you compare 2015 to 2017. And additionally, there was an increasing body of literature that came out showing the safety of early discharge in bariatric surgery, which again may have influenced individual surgical practice. So in conclusion, the standardized ERAS protocol from the MBSA QUIP appears to be both safe and effective, and we're now ready to see the data from other centers that have adopted it to make sure that it supports the Johns Hopkins findings. Thank you very much.
We'll open this for questions.
May I ask, do you think that length of stay was the principal reason for reducing costs?
I think so, yes. It was a major influence. But we also reduced the amount of IV opioids, and I imagine that has an impact as well on patients.
How were you, here, question.
Hey, that's a great paper. Nice to watch it. Quick question for you. Is the amount of cases being done in the open fashion, did it change pre-ERAS to post-ERAS? There's some nice work saying that that has as much of an impact as an ERAS protocol does.
Yeah, we did not find any significant difference in the distribution of the types of procedures between, which I think further emphasizes the importance of the ERAS protocol. Thank you.
Yeah, Stephen Bowers from Jacksonville. Before you implemented this, was it the understanding and communication with the patient that they would be expected to go home the day after operation?
Yes, so generally the patients were aware that they were expected.
But they
to go
still stayed 2.7 days, or did that change with ERAS?
So with the introduction of ERAS, the patient was received
I'm talking
more
about before that.
Before. So they didn't get I believe the amount of education the patient received increased, and that therefore changed their mindset for going home early. So
do you think that just telling them they expect to go home the next day without anything else would have impacted your results?
I think it probably would have.
That's our experience, I think.
Thank you.
Great study. How did you assess implementation of your various components of your ERAS protocol?
That's one thing that we weren't really able to look at, was the compliance with the different elements of the ERAS protocol. And I think that's our next step, would be to look at how many of those individual elements are being met for each patient.
Another question.
Just had a quick question. Great presentation. Was there any change in your post-op diet initiation protocol? Because that frequently can determine length of stay. Was previously like waiting for upper GI on post-op day 1 versus not?
No, we definitely encouraged everybody to be on PO straight away post-op in the post-ERAS period, whereas I think people were more conservative beforehand, and with the increasing literature that came out showing the safety of it, the practice changed with that.
So in pre-ERAS, they frequently waited 24 hours before feeding?
I think, yeah, it was very variable depending upon which surgeon was doing it. So standardized it with the ERAS.
Thank you.
Thank you very much.